Welcome, everybody. We'll start in just about another half a minute. We're very happy to have you here, and welcome to all of you. In the meantime, maybe you can add to the chat where your name and where you're from. Maybe your name we'll see anyway, but where you're from, so we can get to know you for our session. Thanks. I see Ottawa. We've got someone from Ottawa. Hi, Grace. Oh, I've got Boise, Idaho. I've got Utah. And Germany, and another Canada, Puerto Rico, and Singapore. How exciting. And New York, and again, Calgary, and Oklahoma. Yay. Okay, well, keep sharing in Portland, Oregon. Really lovely. New Jersey. Lovely to see you all. Well, welcome, everybody. As you let us get to know who you are, we'll let you know who we are. Welcome, everyone, to the WHO Network, MPOL Network, and its projects measuring population organizational health literacy session. We have a panel session here. We're very pleased again to be participating in the HARC conference. I think Michael said this was the 15th. I think personally I've been to almost all of them, and perhaps all of them, but it's exciting every year to be part of it. So yes, we would like to have this face-to-face maybe next year, but in the meantime, it's wonderful just to keep going together and through this method and this mode. So let's get started. I'd like to introduce our panelists. Today we have Krista Drossmeyer, who is a health expert at the International Coordination Center. I'm just going to move my slide for a minute. Of the MPOL network, and we'll be introducing you to that network and all of the projects doing amazing work. And it's part of the Austrian National Public Health Institute in Vienna. And then I'm really pleased also to welcome Dr. Professor Hanna Soberg-Fintebrunn from the Inland Norway University of Applied Sciences in Norway. Welcome, Hanna. And also our colleague Angelica Schlachter from Schlacher, who's the coordinator of the Australian Health Literacy Alliance. And I'm happy to introduce myself as well. I'm Diane. I'm coming from the University of Haifa, School of Public Health and Clalit Health Services in Israel, beaming in from Tel Aviv, and also is co-chair of the Research MPOL Network. I'm very happy to welcome you here. So let's get started. The objectives of our session are to introduce you all to the WHO Action Network on measuring population organizational health literacy. We're going to introduce you to the international framework and how we build knowledge, or do their best to build a knowledge base on health literacy for people to use internationally, and then discuss what we can learn from this initiative. We're very happy to present 3 current projects: a health literacy population survey, assessing organizational health literacy, and also evidence-based policy and practice projects, which you'll hear more from our guest speakers, and then also discuss together how these projects are contributing to the much needed evidence for health literacy and putting health literacy and its practical implementation on the international research, policy, and practice agenda. So welcome, everybody. So what we will be doing in our session is to have 4 presentations. I will briefly present the project, the network. Then we'll go on to Krista's presentation on the health literacy population survey moving towards 24-25. Then we'll hear about assessing organizational health literacy, both in hospitals and primary care, from Hanne, and then look at our new project on evidence-based policy and practice from Angelica. So to get started, let's have a look at the WHO network for MPOL. And so many of us have different definitions on health literacy. One that maybe some of you have not seen yet, even though it's not all that new, but it does give new perspectives, and that's the one that was published in the WHO Health Promotion Glossary, the update in 2021. and it's health literacy representing personal competency and organizational structure. So we're very happy about putting both of them together within MPOL, looking at resources and commitment, which enable people, as we know, and we'll use for our definitions, to access, understand, appraise, and use information and services to promote health and maintain good health. So this is a definition that really came out after we were even established as a network. And this is also to acknowledge Professor Jürgen Pelikan, who many of you know, who was active every year in HARC, who was one of really the founder of our network and was one of the leading leaders of health literacy, one of the pioneers of health literacy, who unfortunately we lost this past February. So this is also in his memory and in the legacy that he has left us. This is a slide that I love of his, that in 2016 at this conference, Jürgen presented when he took the Parker model and really dived deeper into each of these components. We all know about this model that has the personal competencies on the one hand and situational demands on the other hand, and where health literacy actually is the meeting place. But he took this and really looked into the different aspects of personal competencies, and you can see them all on the left, and the situational demands, which are getting very increasingly more demanding as we become more digital, as you know, and we'll all be talking about that. So you see that on the left, and still be looking within all of that context, how people find, understand, appraise, and apply health information and health resources. And so also it's way background, we're looking at the Vienna model of health literacy, why health literacy matters so much, because we know that individual health literacy, which we want to support through organizational health literacy, and it's definitely influenced by personal determinants. We know it affects health behavior, that affects health status, and also illness behaviors when people have health challenges. So this is to just remind us what the context is, at least for our network and for all of us, of health literacy. So we know we can go into different directions for intervention and action. We can improve people's health literacy skills throughout the life course, but we also need to look at capacity building for organizations to be able to bring down the barriers and enable people to be able to either overcome low health literacy skills or to promote and develop and continually develop their health literacy skills for empowerment. So in order to do this in the best way possible, we really need to understand where the public is and where the population is and where special groups are, which is why the MPOL network was developed. The MPOL network, which is again measuring population and organizational health literacy, was founded in February 2018. On the right, you have pictures of the first group that met together to establish the network. And it currently has 23 member countries, and others are welcome, either as observers or as active members. And it supports health literacy mainly in Europe, but we're reaching out to other parts of the world as well with other partners to provide data to support evidence-informed policy and practice. We do what we do because we want to be able to provide policymakers and clinicians and more researchers with the best evidence possible to make the best decisions for people's health. We focus on personal health literacy and health literacy friendliness of systems and organization. And as you'll see, also strengthen collaboration between research and policy. So I'm not going to go into these definitions, but at the time when we established this network, these were the main definitions that were guiding us, which many of you know. And we built our network on these definitions, particularly the first one, which was really already the first survey based on this was the first survey in Europe that established the tool and established some of the measures that we use till today. But I'm going to go on and show you who the 23 countries are. Some of you are from these countries, and it's nice to see you. And we also have observer countries, and I think we're going to have more in the very near future. So we're really looking as broadly as possible, and you can already understand that we have a lot of intercultural issues to challenge us, which is very exciting, and it makes it really a very enjoyable process to work together and to be able to learn about each other's needs in different countries. And so the projects that we have, the first project was that it was MPOL was collecting data on population in 17 participating countries. And the current projects, which you'll hear from about now, is the next stage, is the next round. One of the most fortunate parts of this network is that we're together for long term. We don't want to just have a cross-sectional study and leave it at that. We want to have it in cycles so we can see trends and be able to really inform what direction the populations are going in different countries. And then also assess organizational health literacy to help organizations, mainly in the healthcare system, to do a better job and to understand why health literacy is so important to achieve the goals that they set out to do. And then of course, policy and practice, because we have to have sustainable policies in place. And this is supported by our Swiss colleagues. So countries, as we mentioned, are either observers or they're members. And just to give you a little bit of highlight, a little bit of a promo, what did we learn from the first study? The first study that we did between 2019 and 2021, which you already can understand that the COVID pandemic, Corona, was actually not expected, but it was part, and we had to take that into consideration. We learned, again, as many of you have seen in previous studies, there's a social gradient for health literacy, and we see that financial deprivation and lower and low reported social status was really strong predictors. We see a higher trend of general health literacy in women. And in some countries, we also see inconsistent results for age and level of education. And that's very interesting because many of the first studies that were done in the US, which some of you are part of, really showed age was a very important determinant. And now we're seeing it really depends. And the other outcomes that we see of health literacy, we're still seeing that it has proven significant effects on general health literacy, and health behavior, some health behaviors, not all, healthcare utilization, and also we understand that's why it's so relevant for public health policy and for clinical health care. So this is just to give you just a small taste of what we've also done in this network, is that we not only measure general health literacy, we have optional packages for the country to look at navigational health literacy. We have a measure for that. It's been published. Digital health literacy, and it's about to be published. Vaccination health literacy, and also communicative health literacy. So these are all subspecialties of HLS and the MPOL network. So we also set out recommendations. How can we improve health literacy based on what we've learned? So we see that low health literacy is widespread and should be widely addressed. We know it's fostered on systems, organizational, and individual levels, and it's in line with the behavioral and cultural insights approach of WHO. So we're lining up with other areas that are getting focused and getting flagged. We know the intervention should then specifically address at-risk groups for low health literacy to reduce health gaps. We also were looking for equity. And also we learned something really important, is that we saw that people were challenged with the quality of health information in the mass media, and also needing more about mental health literacy. And I think as we go on, we're seeing that the world needs to help all of us deal better with what's going on all over the world, and mental health literacy is a big part of it. Getting resources, being able to access information and services in a way that affects their health. So the considerations for specific health literacies were also for navigational health literacy, to get clear pathways so that people can get the best health care that they need and do it easily. For digital health literacy, we wanted to make sure we're investing in digitally available, non-biased public health information on health and illness, and make sure that it's easy for people to achieve. We're not looking at digital divide, we're looking at digital development. And for vaccination health literacy, we focus on improving trustworthiness of information. We all saw what direction we went in with anti-vaxxers and how that affected people's decision making. And also for communication health literacy, communicative health literacy, we need to really invest in curricula and training for healthcare staff. So when you're looking for more information, we really invite you to have a look at the report that was put out in December 2021. And we're actually 2021, the year 2021. It's a wonderful report, very rich with lots of instruments, a lot of important description of the methodology, very detailed, and also looking at the results. But you can also look at fact sheets that are kind of in a nutshell, each of the instruments that we mentioned. And then we also are looking at the, you can also see it here on the, you can also see it here on the web page. So again, this feeds into policy. So these are just examples of countries who have used and will be using MPOL results to establish national action plans for health literacy. And these are really important directions to go in so that we're having sustainable action supported by policy, supported by resources. So with that, thank you for listening to this introduction. I'm going to stop share and I'm going to invite, instead of having a discussion now about this, we're going to go directly into Krista Strassmeyer's presentation on the Health Literacy Population Survey 2024. She'll give us some highlights from HLS 2019 to be able to have a smooth transition to see why we're doing what we're going to be doing in 2024. So Krista, over to you.
Okay, sorry for this. I think I was muted, and I just realized that my screen is going off in a minute. I just need to press 2 buttons. Just give me 1 second. I'm sorry about that. So, can you see the screen?
And not yet. We will as soon as you share it again. We did see it before, and then as you mentioned, it went off.
Okay,
so we're here.
I'm sorry about that.
No problem. In the meantime, maybe our participants can share with us in the chat what countries you're from, or what cities you're from, or what states you're from. And we got an indication in the beginning, and it'd be really nice to see everybody's sharing where you're from.
Can you see the screen now?
Not yet.
Okay, very strange. Not at all?
Yeah, it was there before. We saw it, so we know we know it's there somewhere.
Okay, so hold on, I stop it. Can you see it
Here
now?
you go. Here you go.
Okay.
Perfect.
I'm sorry.
Great. Oh, we got somebody from Arkansas.
Okay. So
I'm watching
a warm
the chat.
welcome from my side. And thank you very much, Diane, for this introduction. As Diane already pointed out, MPOL aims at providing empirical data on health literacy, and this is best done by institutionalizing regular and high quality international comparative population health literacy survey. So when talking about the HLS 24-25, the Health Literacy Population Survey 24-25, it can be best understood when going back to the previous survey, the HLS 19, which is actually the one that we are building on. So first of all, I would like to say that I'm talking here for the HLS 24-25 consortium. And now I would like to give you a bit of an overview what happened in HLS 24. I just realized I jumped the slide. Okay. HLS 19, which was MPOL's first project, was applied a cross-sectional multi-center survey study design. You can see here the 17 countries that participated in the study from Austria, Belgium, Bulgaria, Czechia. So these countries are all from WHO European region. And we had a study population which was defined as all permanent residents aged 18 and above living in private households in the participating countries. So if you look at the valid responses, you can see that we had, basically we said we want at least 1,000 participants for each country, and we had varying participants from 865 to actually 5,660 respondents. And if we take together the full sample, so we had 42,445 interviews conducted in HLS-19. So the participating countries used a multi-stage random sampling procedure, or they used quota sampling. And in most countries actually stratified the samples by gender, by age group, by population density, and by the geographical regions. And data were collected either by personal interviews or by telephone or by web-based interviews. And some countries did use a mix of these. And the time frame for data collection was from 2019 to 2021. We did use as instruments the HLS-19 Q12 or Q47, which were instruments that were based on the first European survey, the HLS-EU survey. And we basically further developed the instrument, and it was validated in MPOL. And also at the first time, we developed new instruments and validated these, and these were instruments on digital health literacy, on communicative health literacy, on navigational health literacy, and on vaccination health literacy. We also looked at the determinants or associations with health literacy for health behavior, for health status, and for healthcare, as well as, of course, we did ask some socio-demographic determinants. So here, I'm sorry, this is jumping very fast. I don't know what's happening with my computer. Hold on, I tried a bit different, sorry. And here's an overview on the categorical levels that we used in MPOL. Here we built on the predecessor study and the HLS-EU study, where there were 4 categories of health literacy, which were defined as inadequate, problematic, sufficient, or excellent. And basically you can see that if bottom line, that on average, 46% of the respondents of all countries had a limited health literacy. That means inadequate, and the categories inadequate and problematic put together. But still, you also can see quite a lot of variation between the countries. If you look at the variation, it's from 25% to 72% with limited health literacy. So in MPOL, or the way the questionnaire, the HLS-19 questionnaire is very much looking at how easy or how difficult it is for respondents to deal with a certain health literacy task. And here you can see the 12 tasks that we ask for general health literacy, rated by or shown according to their difficulties. And you can see that the most difficult task identified was the one judging different treatment options, which was difficult for 43% of all respondents, to decide how one can protect from illness using information from the mass media was the second most difficult task, with 40% finding it most difficult. And actually the easiest task was to ask advice from your doctor, or your pharmacist. And here we have results from using multiple linear regression analysis, where we show the potential effect of general health literacy on health behavior. And we can see that concerning general health literacy, that if people are, the higher the health literacy, the higher is also the fruit and the vegetable consumption. We also could show that health literacy, the higher health literacy, the higher physical activities. and the higher health literacy, the lower is also the BMI. As for associations with the health status, we can see that concerning the self-rated health, people who have less good health literacy actually also have poorer self-rated health. We can see that people with long-term illness or with health problems also reported lower health literacy, and especially those who show that they have limitations to the health problems also find it more difficult to deal with health literacy tasks. As a third category where we are looking at associations, we looked at the issue of healthcare utilization, and we found that people who have lower health literacy have more frequent contacts with primary healthcare physicians, and the same holds true also for specialist doctors. As Diane already pointed out and also already said, we did first in such a large international study also look at specific health literacy, and one of these specific health literacies was navigational health literacy, which in 8 countries and actually in 17 languages. And here we can again see what are the most difficult tasks, and we show that the most difficult task concerning navigational health literacy was dealing with information on healthcare reform or the suitability of a particular health service. The issue of patients' rights was also quite difficult. And the most easiest task was to understand how to get an appointment with a particular healthcare service. So to have this task is also a very good issue on when you want to make any interventions, you really can also see where you can start planning some interventions on. So as for communicative health literacy, we found that 26% of the respondents found it difficult to get enough time in the consultation with their doctor. 18%, for example, found it difficult to express their personal views and preferences to their doctor. And it was the most easiest task was to explain your health concerns to your doctor. And the fourth specific health literacy that we into was vaccination health literacy, especially this has become, especially the issue of vaccination hesitancy has become a pressing public health issue in Europe, and it increasingly poses a challenge to health authorities. And here we have again the difficult tasks, and we can see that 28% of the respondents found it difficult to judge which vaccination they or the family might need. And digital health literacy, again, an issue that has become more and more important the last years. I mean, we have an increasing availability of digital health information, and also the use of health-related digital and electronic resources is putting a growing demand on the population's skills. And as for digital health literacy, we found that 54% of the respondents, so more than half of all people that we asked, found it difficult to judge whether the information that is offered is with a commercial interest. Also, 50% found it difficult to judge whether information they find in digital resources is reliable. So here, quite a high amount of people who have difficulties with issues of digital health literacy. So summing up the HLS-19 results and issues, so basically we developed new measures and they were validated. They showed good psychometric properties, and of course, and still they also show some potential for further improvement, which we are currently actually doing in HLS 24-25, that we are revisiting the tools and how we developed them, and we are on the way on making some improvements. Results also demonstrated the relevance of general and specific health literacies by considerable proportions of adult residents with low health literacies. We did show a social gradient for health literacy, and also some positive association of health literacy with health-related indicators. Also identified specific difficult health literacy tasks and also vulnerable subpopulations with lower health literacy. You also could see for all results that there are considerable variations across countries, which confirm that health literacy is a contextual concept and must be measured for each country. And also, while we did the HLS-19, it was in times of Corona. So we had also a lot of countries had to switch their mode of data collection. So we did have quite a lot of different methods in data collection. Also the time varied. So differences between individual countries, and due to cross-sectional study design, we really have to be also carefully by having causal relations. And nevertheless, results confirm that health literacy is a critical determinant of health, and therefore it is important for health policy to invest in measuring and improving health literacy. Based on the HLS-19 results, we did develop some policy recommendations. One of the specific qualities actually of AMPOL, I would say, is that we are very closely cooperating with research and with policy. And I'm just showing you those recommendations because I'm presenting or coming towards the research issue of HLS 24-25. I just present the recommendations which address research, and it was recommended that health literacy of adult resident population should be measured regularly in as many countries as possible, and that the next wave should be in 2024. So that's what we are working towards currently. In preparation for this wave, more specific research should be funded to further analyze data, to revise, extend, and apply the tools for measuring health literacy and its correlates. That's also what we are currently doing. And for the 4 specific health literacy, more detailed analyses were supported. Additional further specific health literacies should be reviewed, what we are also doing currently. And of course, issues like cost and economics of health literacy should be kept in mind, and further dissemination is required. So HLS-19 did have quite some impact in the countries that participated, and I'm just showing anecdotal examples. Yeah. For example, in Austria, due to the HLS-19 results, the implementation of regions for health literacy is under discussion, with the aim to bring together relevant players from healthcare prevention and health promotion to implement tools to improve health literacy. In the Czech Republic, cooperation with 7 health literacy insurance companies on the issue of improving
Wow, what an answer.
health literacy. I'm sorry, I think I can hear somebody else talk. Maybe there's somebody not muted. Could you all check?
Everybody, please mute if you're not talking. If you're not the presenter, please mute. Thank you.
Thank you very much. Thank you very much. So I stopped with Czech Republic, where there's also a large cooperation between health insurance companies. In Denmark, organizational health literacy has become a big issue as a way to minimize health equality. I do not point out everything from this slide, I just point out one on the second slide. For example, in Slovakia, health literacy has become part of the national health promotion program as an indicator. Or another example, in Slovenia, a health literacy strategy is being prepared by the Ministry of Health and the National Institute for Public Health to improve health literacy. So you can see that HLS-19 did not only just provide data, but it really also has an impact that makes a difference in policy and in practice. So HLS 24-25 is building on this recommendation and is building on these learnings. HLS 24 has a consortium of 19 countries where we are currently cooperating. The key points of the study is it's again a cross-sectional national survey of resident population 18 plus based on probability samples of 1,000 people at least. And we are trying to use mainly CAVI or PAPI-CAPI, which means online survey or personal interviews, either with paper or either with computer. As for the timeline, that's where we are now. Currently, we are developing, improving the instruments, developing the study protocol, and also countries, of course, have to start contracting. So as for the questionnaire, we will develop partly new parts, which we do in English, and this will be translated in the different languages. We again will use the HLS-19 Q12 for the general health literacy. There is a high commitment again to have digital health literacy, communicative health literacy, navigational, vaccination health literacy in the questionnaire. These are optional packages, which means countries can but do not have to use them. And we have two new optional packages, one on mental health literacy. One of the results in HLS-19 was also that mental health literacy is an issue that should be improved, and also distributive health literacy. Distributive health literacy means very much the support, the social support, the support from the social environment that people can get to support them to have to do them for themselves to improve their health literacy. We again, of course, will look at health status, health behaviors, and healthcare utilization. And of course, all countries have the chance also to use their own interests in the survey. So I just go quickly through it. We are currently having for each of these specific health literacy working groups who are actually improving the instruments and discussing research and further research. The same holds true for the correlates, also for the methods. We really look at what have we learned from HLS-19, what can be improved, and that's the way forward. Basically from 2024, first countries will probably already start data collection, and we have a time span from until 2026. We will again do an international report. All countries do national reporting, and again we will do some dissemination work, and of course finally also conclude on policies and see what policies and what practice can learn from our results. So that's it from my part, and I say thank you very much for your attention.
Thank you so much, Krista, for that. That was a very, very rich presentation, summing up the work of years and from many different countries to bring us up to where we are now. And so it is my pleasure, and please put questions and please participate through the chat, because we will take your questions towards the end and have discussion. It is my sheer pleasure to introduce Hanna, Hanna Soberg Finnbretten. My Finnish isn't very good, but it's a warm welcome to Hanna to present the next part of the MPOL project, which is assessing organizational health literacy in hospitals and primary care. Hanna, floor is yours.
Thank you very much, Diane. I'll just switch to the right. So look, just a minute, I'm sorry. There. Is the slides okay
Perfect.
now? Yeah.
Perfect.
Okay.
Thank you.
Thank you very much, Diane, for the introduction. I will present the project of assessing organizational and health literacy in hospitals and primary care. I'm talking on behalf of the MPOL Organizational Health Literacy Consortium. So this presentation will cover why MPOL focus on organizational health literacy in healthcare organizations, the concept and definition of organizational health literacy, the MPOL Organizational Health Literacy Project. I will say something about aims and study design, and I will also present some experiences from the piloting of a self-assessment tool. So first, why does MPOL focus on organizational health literacy in health services? Already from the early 1990s, empirical evidence was produced that health literacy matters for healthcare. First, a considerable number of participants and citizens have low or limited health literacy, and this proportion is likely to increase. As Krista just mentioned, the HLS-19 survey showed that a considerable proportion of the population reported difficulties when it comes to health literacy. Second, patients with low health literacy might have higher use of healthcare services and worse outcomes. Limited or low health literacy has serious effects on the use of healthcare and its outcomes. People with low health literacy have less knowledge about their health conditions and treatment, poorer oral health status, and higher rates of hospitalization than people with higher health literacy. Research also indicates that there is an association between low health literacy and a person's ability to take a decision-making, to keep appointments, to adhere to recommended disease treatment, to implement health-promoting behaviors, and to engage with preventative health services. And third, low health literacy in healthcare also have considerable consequences for the cost of healthcare. Health literacy could be considered as a relational concept. This understanding acknowledges that an actual individual's health literacy does not only depend on their personal skills, but also on the complexity that is the demands and the resources of the situation in which health literate decisions and actions have to be taken. Health literacy was from the beginning introduced as a measurable concept, and so the relational character has consequences for measurement and interventions. By this understanding, not only can personal health literacy be measured and improved, but also organizational health literacy or health literacy sensitivity of organizations. Health literacy is still an evolving concept, and for organizational health literacy, this is even more so. Brack et al. Proposed the definition that health literate organization makes it easier for people to navigate, understand, and use information and services to take care of their health. Brack et al. Also presented the 10 attributes of health literate healthcare organizations. In Europe, I've team of researchers from Vienna, which basically consisted of Mr. Jürgen Pelikan and Christina Dieter, started to develop a more comprehensive framework for health literate healthcare organization with a focus on hospitals. Here you see a more comprehensive definition provided by them, according to which a health literate healthcare organization makes it easier for all stakeholders in a hospital to access, understand, appraise, and apply disease and health relevant information. And it aims to improve personal health literacy for making judgments and taking decisions in everyday life concerning healthcare, disease prevention, and health promotion to maintain or improve quality of life. Health literacy is, according to this framework, not only understood as a core concept of health promotion, but like health promotion, also a core concept of quality in healthcare. Pelikan and Dieter also define the means of how to achieve improvement of organizational health literacy. For a systematic and sustainable implementation, healthcare organizations will have to apply principles and tools of quality management, of change management, and of health promotion. Furthermore, they have to build specific organizational capacities, like infrastructures and, of course, resources, to become more health literate. It is of primary importance, therefore, to develop strategies to allow healthcare organizations to improve their health literacy. Yet, organizations often find it difficult to determine exactly what it means to be health literate. And that's where self-assessment and self-assessment tools come in. Organizational health literacy self-assessment are powerful tools to promote awareness and discussion of current practices, to identify strengths and weak areas for improvement, to gain consensus for prioritizing health literacy intervention, and to stimulate health literacy strategic planning. Now I will present the MPOL Organizational Health Literacy Project. The overall aim of the MPOL Organizational Health Literacy Project is to initiate and facilitate the self-assessment of organizational health literacy in hospitals and primary healthcare services by developing, providing, and disseminating organizational health literacy self-assessment tools. Thereby, we aim to support healthcare organizations to engage with the issues of organizational health literacy, to obtain information about the strengths and weaknesses of organizational health literacy in their organization, and based on that, to improve their organizational health literacy. So, in 2022, MPOL initiated a project on translating, culturally adapting, and piloting a tool, a self-assessment tool for hospitals in cooperation with the working group of the International Network of Health Promoting Hospitals and Health Services. So far, 15 countries from the WHO Europe and some observer countries are into this project. So now we have a self-assessment tool for organizational health literacy of hospitals and one tool for primary healthcare services. These tools are self-assessment tools and not meant for surveys. The International Self-Assessment Tool for Organizational Health Literacy of Hospitals is based on the Vienna concept, which Krista presented earlier. It was developed by a working group of the International Network of Health Promoting Hospitals and Health Services by researchers from Austria, Belgium, Switzerland, Germany, Israel, Italy, Norway, and Taiwan. The tool has 8 standards and 21 substandards and consists of 155 indicators, including some sub-indicators. The indicators for each substandard operationalize concrete, observable, and measurable elements. As mentioned, the tool is developed on basis on 8 standards of organizational health literacy. I would like now to introduce these 8 standards. Basically, the standards describes what healthcare organizations can do to become more health literate. What can hospitals do? They can implement organizational health literacy best practices across all structures and processes of the organization. They can develop documents, materials, and services with stakeholders in a participatory manner. They can enable and train staff for personal and organizational health literacy, and they can provide and support easy navigation and access to documents, materials, and services. They can apply health literacy best practices in all forms of communication with patients. They can promote personal health literacy of patients and relatives. They can promote health literacy of staff, and they can contribute to promoting personal and organizational health literacy in the region. So this is the content then of the 8 standards. And the International Self-Assessment Tool for Organizational Health Literacy in Primary Healthcare Services builds on the organizational tool developed for hospitals and the Organizational Health Literacy Self-Asset developed by Degani et al. The primary healthcare tool was developed within the MPOL 2022 project and is still a draft version. It has 7 dimensions and 15 sub-standards and 65 indicators. The indicators for each substandard operationalize concrete and observable and measurable elements. So let's have a look on the design for translation, cultural adaptation, and piloting of the self-assessment tool. There's an ongoing work on translation, cultural adaptation, and piloting of the hospital tool in Austria, Belgium, Switzerland, Czech Republic, Denmark, Israel, Italy, Norway, Russian Federation, Serbia, and Slovenia, whereas the primary healthcare tool is about to be piloting in Israel, Italy, and Serbia. And there's a recommended procedure for translation of the tools. There's recommended two forward translations, one by the national coordinator and one by the independent language experts. Then the national coordinator compares the 2 translations and decides with the independent experts on the most appropriate translation in case of differences. There are also some recommendations for cultural adaptation with a consensus meeting of the wording of the tool and an optional also about cognitive interviews. After translation and cultural adaptation, the national coordinator or team provides a report to the MPOL, including a version of the tool in the current language. For the national assessment, a multidisciplinary assessment team fills in the tool individually, and then there is offered a joint assessment meeting where indicators with varying assessment are discussed to gain an insight of strengths and weaknesses of organizational health literacy in the current hospital. Based on this self-assessment, the hospital can select areas for improvement or planning improvement measures. When piloting the self-assessment tool for organizational health literacy in hospitals, we are focusing on the 4 of the general areas of feasibility, acceptability, implementation, practicality, and integration, and carrying out internal organizational diagnosis to gain a first insight into strengths and weaknesses of each of the participating hospitals in terms of health literacy responsiveness. So what are our experiences so far? Based on experiences from Norway and Germany, most indicators are considered as relevant. The assessment based on the self-assessment tool of organizational health literacy in hospitals is well suited as a basis for improvement processes. The piloting increased the participants' awareness of health literacy and organizational health literacy. However, the tool is considered as somewhat lengthy, and the wording of some of the indicators were considered as rather academic. So just a brief insight into the Norwegian experiences. Standards with a mean score of 2 or higher could be considered as conservation areas, whereas standards with a mean score of 1 or lower could be considered as improvement areas. Calculating mean scores for the 8 standards, we found in Norway that none of the standards had a score of 2 or higher. From the manager's perspective, the standard with the lowest scores were standard 1, 3, and 8. Among employees, healthcare professionals with daily patients contact, standard 2, 3, 6, and 8 had the lowest score. The employees were only offered 17 out of the 22 indicators of standard 1. Having looked on the German results, the standards with the lowest scores were standard 2 and 3, whereas standard 6 had the highest score. These are scores of the 8 standards. Information about the scores on substandards at indicated level will provide more in-depth information about conservation and improvement areas. And we are planning a report which describe the results on the final level. For primary healthcare, there is an ongoing project in Serbia where the tool is piloted in pharmacies. From this piloting, the experiences is that the instrument works quite well, but as from the hospital tool, the primary healthcare tool is also considered as somewhat lengthy, and some indicators are somewhat hard to understand. So what are our next steps? We are about to revise the tool. The tools are considered as somewhat lengthy, as I said, and hence we are now working on shortening the tool. There are also some new aspects that we would like to add. We are also working on improving the wording of some of the indicators, and the tools are about to be piloting in more countries before a broader dissemination. An international report is also planned. So thank you very much for listening about organizational health literacy. Thank you.
Thank you so much. Thanks, Hannah. That was really an amazing, comprehensive presentation. And let's take a moment or two for any questions for clarification that somebody may have for either Krista or Hannah. We'll take a minute or so just to see. I didn't see anything in the chat currently. But let's see. I'll take a minute for people to maybe collect their thoughts for a second. And sorry. Okay. All right. Well, please get your questions ready and your comments ready. We're going to go. There's something from Grace from Drama. Great presentation. A little off-topic question. Is anyone aware of OHL measures that measure from a patient's perspective how well we can understand, how you can find, understand, and use the health information provides, less so an internal self-assessment organization? So while we look at that question, while we see the next presentation, please see if any of you can answer Grace. And add to the chat some of your experience and what she's asking, and then we can open it up to the discussion afterwards. So thanks so much. Great question, Grace. And use this group. This is a great group for learning. So it is my pleasure now to introduce Angelica Schlacher, who will be looking at a whole different perspective of health literacy that has been part of what we set out to do when we established MPOL, is that look at how we can affect policy. So Angelica has been working on an amazing project, and much of it, some major stuff of it was launched last week, an enormous effort to get it going. So Angelica, the floor is yours.
Thank you, Diane. I hope everyone can hear me. Someone commented on the audio, so I hope the sound is good. It is my pleasure to present the third and youngest project of MPOL, and this project actually rounds it up and demonstrates what MPOL is about. Prepare the data, support evidence-based knowledge, and with this project, give policymakers some tools to use the information that the service generated. And I will dive in right away and give you, here we go, some information. So why this project? That health literacy is gaining more and more interest among policymakers and decision makers. And this guide is meant to support them when it comes to improve health literacy action. And thanks to Switzerland, which is a member of MPOL, this project was funded, and together with WH Europe and the Austrian National Public Health Institute realized. And this guide brings some different insights together. First of all, existing literature on action plans and interventions. Secondly, we collected experiences and good practices from the MPOL members in other countries. And we will also collect feedback in webinars with the target group with policy and decision makers from MPOL members in other countries. And I'll give you an idea what this guide is about. So this is the outline. We start with some sort of introduction. What is health literacy? Why it is important to strengthen health literacy? What are the mandates behind it? And then we move on to the role of health policy and administration of health literacy. And we give a brief overview on main approaches on health literacy action. For example, a top-down approach, a bottom-up approach, or which level should be addressed, a national level, a local level, a regional level, and so on. And then we come to the core of the guide, the cycle of development and implementation. And the working group decided to structure the document following the logic of a public health action cycle. And there are different forms of the cycle, but this is a very basic form. And we organized the whole guide along this structure. So starting with the situation analysis, how to set the agenda, how to develop policies and strategies and interventions, how the implementation of health literacy interventions can be supported, and how to evaluate and monitor those developments. And we conclude the guide with a simple checklist, which is it's a tool to reflect on. Where am I in my journey? Where is my country? Did I do this step? Did I do that step? So it's a supporting tool. And then, of course, there's an appendix, and it's a rather broad collection of examples from different countries. And I will dive into the cycle of development and implementation. And I start with the situation analysis. And we have actually here, and first you have to know what's going on in your population. So analyzing the level of health literacy in your country. Just a second. And it was mentioned in Europe, policies and activities were inspired by the first European Health Literacy Survey in 2011. And Krista pointed out in her presentation the effects, the impacts that the Health Literacy Survey in 2019 had. On a second level, the organization of health literacy needs to be assessed because health literacy of people largely depends on the fit between their abilities and the demands of health services and organizations. A third step would be to look at the regulations, capacities, structures, and processes which are already in place in the context of health literacy. And that could be on a national level, but also on a regional level or local level. And so you would do that. And step 4 would be to identify stakeholders, so do a stakeholder analysis to look for potential stakeholders you would like to include in the process of developing health literacy And it is important to also include insurances, healthcare organizations, universities, organizations for educating health professionals, etc. So what we propose is to do a very thorough situation analysis as a first step in order to place health literacy on the agendas of relevant decision makers. And we are aware that this is not easy. That's quite a difficult task. And based on the experiences from other countries, we summarized a few points that might be helpful. So the first point is to create a sense of urgency. So from data to buy-in, so to speak. And in some countries, it was very helpful to have the data available. For example, in Austria, the data from 2011, they really had an impact. To have available data that is important to create a sense of urgency that something needs to be done. Secondly, it's also very helpful to have these alliances and coalitions. And the development of those alliances are very organic, and they are a very individual process. They are different in every country. They're different in outline. They're different in focus. But there are similar things, and they have some things in common and an important role to play, because they are linking policy, practice, and research. They foster an awareness around health literacy. They do some advocacy. They do some lobbying. And there are a few examples here. I've listed some the countries who have alliances and networks in place. And of course, there are also international coalitions such as MPOL, the Nordic Network, or IGLA. And those networks, they do what we have listed here as a third point. It's awareness building around health literacy. And this can be done through communication, through public relations, through targeted stakeholder communication, webinars, expert exchange, etc., etc. So the next phase is about developing policy strategies and interventions. And in this step, the objectives are set, the costs are identified, and an adequate policy approach is chosen. And we try to summarize current options implemented in different countries. So some countries chose to develop a specific national action plan on health literacy or a specific health literacy strategy. Germany, for example, has an action plan in place. Norway has a strategy on health literacy. And the driver here is that there is really a recognition of a need for coordination and a systematic approach. And in addition, it underlines the political importance of health literacy. There's greater visibility. It involves a range of different stakeholders. It clarifies responsibilities. Those are the advantages. But in other contexts, it might be more appropriate to integrate health literacy in other policies or emerging policies. For example, in general health policies or policies on NCDs, on health promotion, on digital addiction prevention, or cultural appropriateness. The risk here, though, is that health literacy might not be seen as a high priority, and that it might not be brought into implementation. A third point here is what we call using windows of opportunity. And that means a reform process, for example, could be an entry point to put health literacy on the agenda and put it into to make policy. For example, a reform of the healthcare services or a reform of the social security system. And also certain topics can be seen as a window of opportunity. And I mentioned the COVID pandemic, because the pandemic was accompanied by an infodemic, and it was made clear how important health literacy is. And then a fourth point here, in some specific context, it is more appropriate to develop a policy for a specific aspect. And I can name here Austria as an example. For example, in Austria, we developed a national policy for patient-centered culture of communication. To give you an example on that. So the improvement of health literacy interventions of health literacy needs interventions on different levels. And it is important to say that there is no size-fits-all strategy when it comes to implementation. Also, interventions cannot be seen as standalone. In many cases, they are intertwined, and they are even more effective when they are combined. And we also, again, try to summarize and provide examples of successful steps taken to put policy into practice on a macro, a meso, and micro level. So on a macro level, I would like to mention the Austrian Health Literacy Alliance. This is where I work, and the Austrian Health Literacy Alliance has the role of a national steering and coordination body, for example. Also, a large-scale intervention would be are communication training programs countrywide, and also embedding health literacy into government legislation, regulation, and funding are very important actions. To give you an example, for example, in Germany, health insurance organizations are now obliged to promote digital health literacy for their members. And related to that, digital technologies, they transform the healthcare system, and they transform people's access to information. So specific regulations regarding digital tools are recommended, and they already exist, actually. And regulation on a macro level, that should enable the meso level, so the level of healthcare organizations, educational organizations, workplaces, and local communities. So they can design their structures and processes in a health literate friendly way. So to be successful, it is important to have support from health policy. And what should be done? What is recommended? So it is recommended that health policy include organizational health literacy in national health targets or action plans, or integrate them in standards and accreditation systems. On a meso level, and Hanne already mentioned it, self-assessments are a very good method for evaluating and developing health literate organizations. And when designing structures and processes in a health literate friendly way, that will support the people and help people to make better decisions for their health. And this is what I'm talking about, and which is about the interaction between patients and the healthcare system. And actions here would be specific staff trainings, providing materials, on-site trainings. And we also recommend to strengthen citizen involvement. This point, it's still sparse. So we recommend to stimulate development in that field. And finally, it is very important to check whether actions and policies are effective and goals are achieved. And we distinguish two parts here. First, it's evaluation, meaning that there are certain measures to assess, are things working well? Is the quality okay? Are the outcomes okay? Things like that. And the other level would be monitoring, which means regular measurements of health literacy in a country on a national level or also an organizational level. And this is the aim of the MPOL network. And so there are surveys, population surveys, regular, to have comparative data. So, and I'll tell you that we checklist at the end of the guide, and this is just a snapshot, so you know what I'm talking about. It's some questions, potential answers, and it's also structured like the cycle. And then you can policymakers and decision makers can reflect where are they. So it should stimulate some thinking, and yeah, so this is a tool to help. So what are the next steps? On December 6th, we actually have a webinar for the target group, stakeholders and administrators, and we will present the guide and collect their feedback and thoughts on the guide. After that, we'll finalize the guide and we will produce a video along with it, and that will be used for dissemination. So that was a very quick overview of this very young project, and also thank you for your attention from my side.
Thank you so much. It's a young project, but see how much progress has been made. And I think it highlights one of the most important parts of the MPL structure is that in every country, by the way, can you hear me okay? I noticed in the chat some people were saying you couldn't hear. We have from every country, we
Can hear
have
you good, yeah.
Thanks. We have a researcher, someone who's leading the research, and someone's from the policy aspect, working together to lead together so that we can immediately feed into policy, and also policy can help direct the research and, of course, practice. So that answered maybe a couple of the questions that came up in the chat. So thank you. And also thank you, Krista, for answering as we go. So please feel free. We have some time now. And if you want to open up a camera or open up your mic, and ask some clarification questions, give some comments, maybe help each other in some of the questions that came up. And we're really happy to hear from you. You've been presented with a very, very rich and very comprehensive project that is only 4 years old. And we're going to hopefully go forward for more than just one more cycle. So your input and your questions here will help us as well. So who would like to start? Or any questions that came up in the chat that have not yet been answered? I can say for the primary healthcare self-assessment, one of the reasons we have it as a self-assessment is not just for the outcomes of the assessment, but also for the process. Something that's really important that we're striving for is when teams come together to do the self-assessment, it creates discussion about health literacy, it creates some mutual understanding, and then we can also see where the gaps are about what each one means on health literacy. So it's not just to have an assessment or have some accreditation, as was mentioned, it's really to get the discussion going and keep it going on the level of the organizations, whether it's primary care or the hospitals and their departments or through sectors, whatever. So that answered another question that came up.
Maybe I can also add for the primary healthcare organizational health literacy assessment, our Serbian partner is using that for pharmacies, and first results are quite promising that it's also suitable to use it in pharmacies.
Which is really helpful because for many people in the healthcare system, pharmacies are seen as a dispensary and not as a source of health information and empowerment, but we all know it is, but it isn't always considered that and hasn't been included enough in research, in practice, in guidelines. So the Serbian experience is really valuable. Other questions, comments, concerns? And also, this is also just to mention, I don't know if we highlighted it enough. This project could not take place just by collaboration between countries. It really takes leadership and it takes coordination. And so the countries have come together to develop the whole concept of an international coordination center, which is more than critical. And that's what Krista leads with a couple other colleagues and keeps us all together, working together, keeps us organized. We have a constitution as well, which also helps set the rules for how we communicate and how we work together, how we publish together, how we innovate new ideas together as well. So it is, I think, pretty exemplary. We haven't seen it that many around the world, and it takes a lot to sustain and maintain, but as you can see, we're hoping for more and more results. So, have any of you done, for example, assessments in primary care for health literacy? Can somebody share? I know hospital work is pretty prevalent. And some of the early research that was done by Michael here and others was in hospitals. Primary care gets less attention for obvious reasons. They're, I think, a lot more heterogeneous. It's a lot more fragmented. Doesn't, depending upon what country you're from or what state you're from. Any challenges anybody would like to share about primary care, which is challenging, definitely in the States? Or in any of your countries? People are here from Canada, so I'm from Puerto Rico. We've seen some other countries represented here. Anna, I have a question for you. And you're very, very active in the hospital. You're active in almost all of the work packages, maybe all of them. In the hospital group, which I'm a part of, but you're much more active. How do you feel about the fact that hospitals play different roles in different countries? And how does that work in the self-assessment? And how do you think we'll be able to work together to bring the data together? And is it comparing, or will it be sharing? What do you envision will happen with the results of that self-assessment?
That's a very interesting question, Diane. I think that some of the indicators, and probably most of the indicators, might be relevant all across the European countries and also maybe in other parts of the world as well. But some of the indicators might be more relevant in some countries than others because of politics and laws and something like that. But the tasks of hospitals and providing information and services that are easy, accessible, understandable, and that the users can apply and use, I think that is relevant for all countries. So the work now with shortening the tool, I think we also should have that perspective in mind to keep indicators that could be relevant, or that the indicators that are most relevant across countries. But the healthcare system and politics and so on differs across the countries, so that might have an effect on the relevance then. But yes, that is an issue that we should discuss further, I think.
Thank you. Angelica, can I ask you a question? Unless others have questions from our participants, again, I'll give you the floor.
You have a question
first.
from Kathy Mead.
Do I see I thought maybe that was answered, but I missed that. Let's see. Kathy, would you like to ask the question through your mic? In study one, is that the question on gender? Any gender
No,
variations?
thank you. I can't get my camera on. I think that's locked. But I was just wondering if there was some mention of how important context is. So when you think of the studies that have really spanned all of the countries, maybe each of you might speak to some of the cultural nuances that you're finding that are so important to, the advancement of this field. As we try and calibrate things and get consistency and reliable instruments and tools, even how questions are worded and phrased and all of that. Just curious your thoughts on that.
Thank you. That's perfect. That's a wonderful question because it also invites us to talk a little bit more about how we culturally adapt the tools in MPOL. We have a really rigorous process. And with the many years I've been working in this field, I think we're getting more and more rigorous, I can say. We're getting we're demanding more about the cultural aspects of our tools and doing cultural adaptation, doing professional translation, back translation, focus groups to validate, and both with the people from the community and also with professionals, because it is so critical. And I think we're realizing it from phase to phase. If you like, I think there's a location I can recommend about how we did it, for example, in the Russian, from 3 different countries, how it was adapted to people from Moscow, how it was adapted to Russian immigrants in Israel, Russian immigrants in Sweden, and also Russian immigrants to the US in Hawaii. And we compared the way in which this one tool was translated in different ways with different connotations and different contexts, and how it was so important to really do that, have that as part of the process of making the tool much more reliable and adapted to the context. So it's not just language, it's the cultural context of that language as well. We're seeing it now with Arabic. I can say from the tool that we translated in Israel in Arabic, back translated and then validated, giving it to other countries. For example, in Sweden or other countries, it's a different context of Arabic. It could be people coming from migrants from Syria in Sweden, and they may have different terms in Arabic for the healthcare system, or those in Germany. We saw that some in Germany, for example, the Russian immigrants, they knew the term in German for healthcare rather than Russian, because that's how they're using the healthcare system, is using the German terms. So it's really, it's fascinating, it's important, it's critical, and your question is really on spot for what we do. We missed a lot in that stage. I don't know if that answers your question. And maybe also Hannah or Krista or Angelica, would you like to also share?
I think it's fine what you said, Diane. Thanks.
Yeah, thank you so much.
Also, if you'd like to see more in the report that we mentioned, there is a detailed overview of how we do that in different countries, how different countries did that process, and how we're coming together to get it a little bit more homogeneous.
Great. So, thank you for the panel for presenting about this ongoing work. It's a very large effort, and I'm hoping that you guys will have the stamina needed and the collaborations growing to make it all happen. Continuing to grow. So we actually need to invite people to check out the posters. There's a 30-minute gap now in the panels. If you go back to the homepage for the conference, there's a tab for posters, and you can view posters there. Some of them have associated videos of the presenter of the poster talking about their work. And then in 30 minutes, we'll have the next sessions. If you can, I hope you will all be able to join us again for the next panel. So congratulations. Thank you all again, and be well. I hope to see you in the next rooms.
Thank you so much, Michael. Good to see you. Good to see you all. Thank you all so much for joining. And please visit our website and stay in touch. And thank you so much to the panelists, Hannah, Krista, Angelica. Thank you so much for your presentations. Wonderful.
Yeah.
See you all.
All right.
Enjoy the conference.
Yep. Bye-bye.